Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam, and today we are going to learn about pulmonary hypertension. This would include both the pulmonary arterial hypertension and other causes of pulmonary hypertension. This is a field which covers both the pulmonary and the cardiovascular systems. So let us begin. The objectives of this presentation include the definition of pulmonary hypertension, epidemiology, etiology, pathophysiology, history and physical examination, diagnostic tests, management, and prognosis. The definition of pulmonary hypertension. Pulmonary hypertension is a condition where there is progressive increase in the pulmonary arterial blood pressure, leading to right heart failure and death. Pulmonary hypertension is defined as a mean pulmonary artery pressure of greater than 25 millimeters of mercury at rest, with a normal pulmonary capillary wedge pressure of less than 15 millimeters of mercury. It is said to be borderline if the mean pulmonary arterial pressure is between 20 and 24 millimeters of mercury. Now let's look at the classification of pulmonary hypertension. According to the data point WHO classification, pulmonary hypertension is broadly divided into 5 major categories. The first one is known as the pulmonary arterial hypertension, or designated as a PAH, and it is an idiopathic primary pulmonary hypertension that is primarily resulting from changes in the pulmonary arterial circulation. The second type of pulmonary hypertension, which is designated here as just PH, which stands for pulmonary hypertension, is due to left heart disease, namely pulmonary venous hypertension. The third category includes diseases related to respiratory conditions and or hypoxia, such as chronic obstructive pulmonary disease, interstitial lung disease, etc. The fourth group is related to chronic Thrombo Embolic pulmonary hypertension, and finally the fifth group is of conditions which are unknown. Now let's look at group 1, which is a primary pulmonary hypertension or pulmonary arterial hypertension. Before we go any further, let us look at the pulmonary arterial, capillary, venous and pulmonary venous circulation, or the circuit. As we know, the main pulmonary artery divides into pulmonary branches, which divide into smaller and smaller pulmonary arterioles and arteries, and there is a dramatic change in the pulmonary arteries in patients with pulmonary arterial hypertension. The second group involves the diseases related to the pulmonary venous congestion, increase in pulmonary venous pressure related to left heart failure and its associated symptoms. The third group involves the pulmonary lung bed itself, which involves the arterioles and capillaries, along with the alveoli, where there is involvement of the lung tissue secondary to COPD, interstitial lung disease, etc. So let's talk about primary pulmonary arterial hypertension, or PAH. It could be idiopathic or heritable. Sometimes they may be related to drug or toxic substances. It could be associated with CTO, HIV, portal hypertension, or schistosomiasis. Pulmonary arterial hypertension is a progressive disease with a 50% survival rate at 2.8 years. This disease can lead to sudden death. It affects generally younger adults, the mean age being 45 years, and rarely it is familial. Here are some of the changes that we see in patients in the pulmonary arteries and arterioles, which we will discuss in detail in a moment. The second type of pulmonary hypertension is related to left heart failure, which can result from systolic or diastolic dysfunction, valvular heart disease such as aortic stenosis, mitral stenosis, mitral regurgitation. It could be related to pulmonary venous obstruction, and sometimes it may be related to congenital heart diseases such as atrial septal defect with pulmonary hypertension or Ising-Menger syndrome. And there are a few other conditions that can cause left ventricular failure such as cardiomyopathy, myocarditis, etc. The group 3 is the one that involves the pulmonary parenchyma itself, that is a lung tissue which is affected by chronic obstructive pulmonary disease, pulmonary fibrosis, chronic bronchitis, idiopathic lung disease, sleep disorders, alveolar hypoventilation, and many other conditions. And these can generally be diagnosed by a chest X-ray or a CT angiography and pulmonary function tests. Now let's talk about group 4 pulmonary hypertension. Group 4 is related to chronic thrombo embolic pulmonary hypertension, and as you can see, here is a CAT scan showing a very large pulmonary embolus. With the modern techniques, now we are able to remove these blood clots from the major pulmonary arteries using catheter techniques or even vascular surgery, and dramatically improve their overall pulmonary function. One of the key words they are going to ask you is, how do you screen patients for thromboembolic pulmonary hypertension? And the answer is VQ scan. Group 5 is the secondary type of pulmonary hypertension related to collagen vascular diseases such as scleroderma, systemic lupus erythematosus. It can also be related to liver disease, congenital heart, hemolytic anemia, and metabolic disorders. Here is a summation of all the 5 categories of pulmonary hypertension, of which only group 1 is the primary pulmonary arterial hypertension. Here is a study showing that more than 78% of the patients who present with the pulmonary hypertension are due to left heart disease. As you can see, the thromboembolic accounts for 0.6%, whereas primary arterial hypertension accounts for approximately 2.3% of the patients we encounter in clinical practice with pulmonary hypertension, and about 9.7 or 10% of them are related to chronic lung disease, and another 2% related to congenital heart diseases. I talked briefly about the pathophysiology of pulmonary hypertension in the 5 groups of patients, and of course the pulmonary arterial hypertension relates to the changes in the vascular bed in the pulmonary arteries, whereas group 2 involves changes related to increased venous pressure from left heart failure, whereas group 3 involves the lung parenchymal tissue, and group 4 involves the major pulmonary arteries by thromboembolic events, and the 5th group is the miscellaneous group. Let's look at the pathology of vascular changes we see in patients with pulmonary arterial hypertension. The main changes that we encounter are smooth muscle cell hypertrophy, intimal thickening, adventitial thickening, and plexiform lesions, namely focal proliferation of endothelial channels. Here is an expanded look at the pathological specimen of an artery from a patient with pulmonary arterial hypertension. As you can see, there is disruption of the endothelial layer. There is proliferation of the smooth muscle layer along with the thickening of the adventitia of the arteries and arterioles in the pulmonary circuit. Here is a gross specimen of a patient with pulmonary arterial hypertension. As you can see, the lung tissue is pretty dense and the arterioles appear to be thicker. Now, let's look at what causes this arterial thickening. What stimulates the smooth muscle proliferation, adventitial growth, and endothelial dysfunction in these patients? There are three major pathways seen in patients with pulmonary arterial hypertension that accounts for endothelial dysfunction along with the proliferation of the smooth muscle cells. The first one is the endothelin pathway. The second one is involved with the prostaglandin through the prostacyclin pathway, and the third one is through inhibition of the nitric oxide pathway. The endothelin pathway involves the production of endothelin 1, which acts on endothelin receptors A and B. It causes vasoconstriction and proliferation of smooth muscle cells. There is inhibition of the prostacyclin pathway. As a result, it prevents vasodilatation and anti-proliferative properties. Similarly, nitric oxide is supposed to increase cyclic GMP, which leads to vasodilatation and anti-proliferation functions, and because this is blocked, that can also lead to pulmonary arterial hypertension and the vascular changes we see on pathology. By understanding the mechanism by which there are arterial changes in patients with pulmonary arterial hypertension, we are able to find drugs that can alter these pathways and thus improve the symptoms and quality of life in patients with pulmonary arterial hypertension. Patients with pulmonary arterial hypertension have significantly elevated pulmonary arterial mean pressures. Along with significant changes in the vascular bed, their lungs are not able to keep up with the increased demands during exercise. If you look at the pulmonary arterial pressure in a patient with normal circulation, their resting pressures may be somewhere 15 millimeters of mercury, and as their cardiac output goes up, there is minimal increase in the mean pulmonary arterial pressure. But in patients with mild to moderate pulmonary arterial hypertension, because of the fixed nature of the pulmonary arterial bed, there is a dramatic increase in the mean pulmonary artery pressure with increased cardiac output related to exercise, and this can also lead to significant dyspnea. And as you can see in patients with severe pulmonary hypertension, there is a dramatic increase in pulmonary arterial pressure with minimal exercise, and we may see similar changes in patients with rapid heartbeat where there is reduced diastolic filling time. Now let's look at some of the symptoms with which these patients present. Generally, the symptoms are non-specific, which usually leads to a significant delay in the diagnosis of pulmonary hypertension, especially pulmonary arterial hypertension. Dyspnea on exertion is one of the main features of patients with pulmonary hypertension. Some patients may also present with syncope, especially with exertion, and as you can see from the previous slide, why they are not able to increase their cardiac output with exertion. Chest pain may be related to pulmonary arterial pressure. Significant increase in pulmonary arterial pressure, these patients can develop leg edema, which could be a sign of right heart failure. On examination, we may be able to feel the right ventricular heave. There may be a loud systolic murmur in the left parasternal area related to tricuspid regurgitation, and you may hear a loud pulmonic second sound. And if it's secondary pulmonary hypertension, we may be able to see signs of lung disease or left-sided heart failure. The diagnostic tests would include electrocardiogram, chest X-ray, EKG, echocardiography, airway reactivity tests, pulmonary function tests, and finally right heart catheterization to diagnose pulmonary arterial hypertension. So most of the discussion here onwards would be focused on pulmonary arterial hypertension, since we know how to identify the other types of pulmonary hypertension and treat the underlying etiology. In patients with pulmonary hypertension, we can see right atrial enlargement on the electrocardiogram along with right ventricular hypertrophy and strain pattern. There may also be right axis deviation, as we can see here in this electrocardiogram, and some STT changes related to right ventricular strain. These patients can also develop atrial fibrillation and PACs due to enlargement of the right atrium. Chest X-ray can show elevated cardiac apex in patients with significant right ventricular hypertrophy. There may be enlargement of the right atrium, prominent pulmonary arteries, dilated pulmonary segments, along with enlarged pulmonary arteries, which talked about. Then pruning of the peripheral pulmonary vessels. There is pruning of the peripheral arterial markings. Echocardiography is one of the important tests to identify not only the presence of pulmonary arterial hypertension, but also other conditions particularly related to the left heart failure. Echocardiography will help us to identify right ventricular hypertrophy, left ventricular hypertrophy, right atrial enlargement, left atrial enlargement, is a specific type of a septal position and motion, which I'm going to talk about in a minute. Wall motion abnormalities related to the left ventricle or the right ventricle. Then looking at left ventricular systolic and diastolic dysfunction, right ventricular systolic dysfunction by measuring TAPSE. Then we can also identify valvular problems such as aortic stenosis, mitral regurgitation, pulmonary tricuspid regurgitation. Pulmonary artery pressure, of course, is one of the main measurements by which we, of course, identify patients with pulmonary hypertension, and echocardiography is as accurate as cardiac catheterization in terms of identifying pulmonary hypertension, even though there may be some variations in the pulmonary systolic pressure. But the beauty of echocardiography is that we can changes in pulmonary arterial pressure based on patient's overall condition and the underlying pathology. We can also see the presence of a pericardial effusion. We can use bubble studies to look for any intracardiac shunt. Echocardiography is also useful in assessing severity and prognosis of patients with either pulmonary arterial hypertension or patients with secondary pulmonary hypertension. Here is an example of an echocardiogram of a patient with pulmonary hypertension. Some of the hallmark findings in patients with pulmonary hypertension include significantly dilated right ventricle, which can be almost 2 to 3 times the size of the left ventricle. Again, significantly dilated right atrium, which could be 2 to 3 times as big as the left atrium. There is severe tricuspid regurgitation, which also reflects the pulmonary arterial systolic pressure. Here is an example of a cross section of an echocardiogram of a patient with pulmonary hypertension. Here we see the classic D sign, that is, instead of the left ventricle being like a donut, now we see a D sign where we have a straight line representing the septum. The septum is flat. Sometimes we can see a paradoxical septal motion. The left ventricular cavity may be reduced if we are dealing with the primary pulmonary arterial hypertension. And as I mentioned before, the right ventricle could be significantly enlarged, and there may also be evidence of right ventricular systolic dysfunction. Here you can see the paradoxical motion of the septum during systole, where the septum is moving towards the right ventricle instead of the left ventricle. Again, the right ventricle is significantly dilated compared to the left ventricle. Here is a line diagram showing what the normal ventricle should look like and what a ventricle in a patient with pulmonary arterial hypertension looks like. This is the D-shaped left ventricular outline with increased right ventricular size. Of course, if you are dealing with thrombo embolic diseases, CT angiography is a gold standard for diagnosing pulmonary embolus, and you can see this a big filling defect in the main pulmonary trunk representing a large pulmonary emboli. Right heart catheterization is the ultimate way to differentiate between pulmonary arterial hypertension and pulmonary hypertension secondary to left ventricular dysfunction. Just to give you a right heart pressure basic morphology, here we have the catheter in the right atrium and we can see the right ACV waves. Then we have the right ventricular pressure here represented by the atrial kick and the systolic right ventricular pressure. Then we have the catheter in the main pulmonary artery. Now we have the pulmonary systolic and diastolic pressures. As the catheter is advanced into the wedge position, we get the wedge pressure, which more or less corresponds to the diastolic pressure, except in patients with the pulmonary arterial hypertension, where the wedge pressure actually reflects the left ventricular end diastolic pressure. In patients with the primary pulmonary arterial hypertension, the right heart pressure, the pulmonary wedge pressure is supposed to be less than 15 millimeters of mercury, whereas in patients with the secondary pulmonary hypertension due to left heart failure may have significantly elevated pulmonary capillary wedge pressure of 20 to 24 millimeters of mercury. That's how we differentiate between pulmonary arterial hypertension and pulmonary hypertension secondary to heart failure. A Swan-Ganz catheter is used to perform the right heart catheterization in order to assess how well they have vasoreactivity. We can challenge these patients with drugs such as ipoprostenol, adenosine or nitric oxide and look for changes in the pulmonary mean pressure. If there is a decrease in pulmonary mean pressure of greater than 10 millimeters of mercury with these vasodilators, then there is a chance these patients will improve when they are treated with calcium channel blockers. After we perform the right heart catheterization and do a vasodilator challenge, if they respond, then these patients will be started on calcium channel blockers. If these patients do not respond, depending upon their symptom classification, we can use vasodilator therapy such as endothelin receptor antagonists or phosphodiesterase 5 inhibitors or prostacyclin analogs. If there is no improvement, newer forms of drugs which are supposed to improve the pulmonary vascular resistance, then these patients should be considered for possible lung transplant. Now, this chart looks at the functional classification of patients with pulmonary hypertension. Class 1 includes patients who do not develop any symptoms such as dyspnea, fatigue, chest pain or syncope with ordinary physical activity, whereas class 4 involves patients who have symptoms at rest and they may have evidence of right heart failure, whereas class 2 involves patients who are comfortable at rest but are symptomatic with ordinary physical activity. And class 3 includes patients who are markedly limited in physical activity and who have symptoms with minimal physical activities. And this classification is used to determine what type of drugs should be used in these patients, especially with the pulmonary arterial hypertension. The main goals in the management of patients with the pulmonary arterial hypertension include increase in survival, improve quality of life, enhance exercise performance, and this is measured by 6-minute walking distance. Positive hemodynamic changes, as we talked about in right heart catheterization. Prevent complications, and finally slow the progression of disease, especially in the pulmonary arterial bed. The general medical management includes salt restriction, diuretics, oxygen to maintain an oxygen saturation of greater than 90% at rest and with activities. They should all be receiving flu and pneumococcal vaccination. Digitalis may be needed in patients with heart failure. Anticoagulation may be necessary in some of these patients, especially with Thrombo Embolic disease, and we have to keep the INR between 1.5 to 2.5. Bronchodilators are of very limited value in patients with pulmonary arterial hypertension, but they may be the main drugs that we may use in patients with chronic obstructive lung disease or chronic bronchitis, asthma. And all of these patients should be enrolled in a supervised exercise training. Now, there are various classes of drugs that are available for managing patients with pulmonary arterial hypertension. They include calcium channel blockers such as diltiazem, endothelin antagonists, phosphodiesterase inhibitors, and prostanoids. In the early part of this presentation, I talked about the pathogenesis of arterial changes we see in patients with the pulmonary arterial bed, namely the altered endothelial function along with reduced prostacyclin activity and reduced nitric oxide activity. These drugs are directed towards modifying those abnormalities we see in patients with pulmonary arterial hypertension. And here these drugs are used based upon their classification related to symptoms and also mean pulmonary arterial pressures. If the mean pulmonary arterial pressure is between 25 to 35, we can use calcium channel blockers, endothelin antagonists, phosphodiesterase 5 inhibitors, or prostanoids. However, when we are talking about patients with severe pulmonary hypertension or patients who have class 4 symptoms, then we are talking about inhaled iloprost, subcutaneous treprostinil, or IV epoprostenol. Let's look at some of the drugs that are available based on the pathophysiology of changes we see in the arterial bed in patients with pulmonary arterial hypertension. We talked about endothelin dysfunction in patients with pulmonary arterial hypertension. In patients with pulmonary arterial hypertension, endothelin 1 especially acts on endothelin receptors A and B that leads to severe vasoconstriction and proliferation. Thus, we have drugs that can inhibit the effect of endothelin on the endothelin receptors, and there are 3 drugs in this category, namely vasentan, ambrisentan, and sesectentan. And in the nitric oxide cycle, we have sildenafil, which is a phosphodiesterase 5 inhibitor, which increases the cyclic GMP that stimulates protein kinase, which results in vasodilatation and anti-proliferation. The same thing is accomplished by the prostacyclin drugs that enhance the action on the ATP and the cyclic AMP, which increases protein kinases that leads to vasodilatation and anti-proliferation of the smooth muscles of the arterial bed. The endothelin receptor antagonists group include non-selective A and B receptor inhibitors, namely vasentan and macitentan, and a very selective alpha receptor inhibitor, namely ambrisentan. And as you can see here, the endothelin 1, which acts on receptors A and B, are blocked by these drugs. Similarly, prostaglandin I also blocks the production of endothelin 1, which leads to vasodilatation and anti-proliferation in patients with pulmonary arterial hypertension. In a sense, all these endothelin receptor antagonists block the endothelin 1, which as we know is a potent vasoconstrictor. Now let's look at the prostacyclin agonist. Those that promote the prostacyclin activity, that includes epoprostenol, which is given intravenously to patients with class 4 symptoms. So the way to remember, epoprostenol is given IV for IV patients or class 4 patients. Then we have these other drugs which are also increase the prostaglandin production, which leads to vasodilatation. The drugs in the phosphodiesterase inhibitor group include sildenafil, which is Viagra, and also tadalafil. They increase the cyclic GMP, which promotes nitric oxide production. And as you know, nitric oxide is a potent vasodilator. It also relaxes the smooth muscles. Pulmonary arterial hypertension is a progressive disease. As I said in the beginning, 50% of the patients are dead by a mean 2.8 years. These patients need to be monitored very closely with a 6-minute walk goal of greater than 300 meters. They should also be followed by BNP measurements for evidence of right heart failure, sequential echocardiography to see the size and function of the right heart, and other studies depending on the context. In chronic pulmonary emboli, pulmonary thromboendarterectomy is an important consideration to remove large clots, and by removing large clots we can dramatically change the pulmonary pressures in patients with thromboembolic disease. If all medical measures fail, we should consider atrial septostomy. When all other modalities of treatment fail, the only option that may be left may be organ transplantation, which may include double lung transplantation and heart and lung transplantation. Another important point I want to emphasize is the delay that is involved in diagnosing patients with idiopathic pulmonary arterial hypertension. Because they are having minimal symptoms to begin with, they are generally not diagnosed until they reach a far advanced stage. By the time we diagnose these patients with pulmonary hypertension by echocardiography and right heart catheterization, they may be in stage 3 or 4. As a result, the disease progresses very rapidly. It is important to pay attention to some of the findings we see on echocardiography. If there is no explanation for an elevated right heart pressure in patients with normal lung function and no evidence of heart disease, we should think about pulmonary arterial hypertension and look for any evidence to support that, and if necessary perform right heart catheterization to see if they indeed have pulmonary arterial hypertension and exclude any secondary causes such as left heart failure. Anytime a patient presents with a new onset of exertional dyspnea, keep in mind primary arterial hypertension. 2D echocardiography is an important test in screening patients with pulmonary arterial hypertension, looking for elevated right heart pressures, looking for tricuspid regurgitation, looking for right ventricular dilatation and dysfunction. And of course, the definitive diagnosis is going to be done by performing a right heart catheterization, measuring the pulmonary mean pressure along with the pulmonary capillary wedge pressure. Several new pharmacological agents are available to specifically treat the underlying pathophysiology in patients with pulmonary arterial hypertension. However, the prognosis of these patients, especially those in class 3 and 4, are limited despite all these newer modalities of drugs being available. Pregnancy may cause significant challenges. So, ladies and gentlemen, this is an overview of pulmonary hypertension. Whenever someone presents with exertional dyspnea with no evidence of a heart or lung disease, just don't ignore or think they are just anxious. Think about pulmonary arterial hypertension. Thank you very much for watching this presentation. I am Dr. Nik Nikam, and please do subscribe to our YouTube channel, and please do visit our cardiology lecture series where we have more than 100 topics covered in the field of cardiology. Please do share this information with your friends. Thank you so much for your time.